Hey, so a very good evening to everybody. I make the time 7:30, which means it's time to kick on with June's film reading session. Thank you all for joining me, and I hope everybody has recovered from the football yesterday evening. So for those of you who are new to these sessions, just a very brief introduction. My name is Ian Jones, and I'm a radiologist. I graduated from the Royal Veterinary College in 2004, and I got my MRCVS certificate in diagnostic imaging in 2009. I went back to the RVC in 2013 to do my imaging residency, and I got my European diploma in 2018. And these days you can find me at London Veterinary Specialists, which is the only multidisciplinary referral hospital in central London. And if you have any questions regarding any imaging that you're planning, if you're wondering what would be the most appropriate imaging modality to use given a particular diagnosis that you're chasing, or if you'd like a hand interpreting some radiographs, then you can give me a call on that number at the clinic, or you can drop me a little note via that email address. So one of the things that we have been doing this year is utilizing online polling software called Poll Everywhere. So for those of you who would like to take part online, I'm hoping that some of you will be willing to report and discuss some of these cases with me. But if you're a little bit reluctant to do that, but you'd like to get involved, then you can go to pollev.com and plug in my username, which is IanDavidJoni636. And then at various points during this evening's session, you should see some questions appear. If you could then respond appropriately, we can then collate all of the results and discuss the results together as a group, and hopefully that'll create some interesting discussion points for us. So before we kick off, we'll just look at an example. So this is a case that we looked at last month. It's probably my favorite case from last month, and I think this is one of the nicest cases that we've had for a while during these film reading sessions. It was a 2-year-old female neutered otter cat that presented to the clinic after being involved in a road traffic accident. Now, I wanted to look at a single radiograph for this patient because we reviewed it comprehensively last time. But one of the things that I want you guys to look at here is the trachea, essentially. So there's lots going on in this radiograph. There is a diffuse, patchy interstitial pattern. So there's lots of areas of increased interstitial opacity throughout the pulmonary parenchyma. There's a megaesophagus, so we can see the dorsal and the ventral walls of the esophagus here. And we've got a whole bunch of gas on the stomach as well, so there's a whole bunch of aerophagia. And we've got this sort of streaky opacity within the craniomediastinum too. So there's tons of things that are distracting us from the most pertinent imaging feature in this radiograph, which is this structure here. So we've got a clearly marginated, round, gas-filled structure just superimposed over the tracheal wall at the level of the hilus of the heart. And in this region, it's very difficult for us to confidently identify the dorsal and the ventral walls of the trachea. In fact, this structure, the dorsal and ventral walls of this structure almost look like they're contiguous with the dorsal and ventral walls of the trachea. And these imaging features are absolutely typical of a tracheal avulsion. So this unfortunate pussycat has avulsed its trachea. And what happens is the neck is hyperflexed, hyperextended, and as a result of that, the trachea, the body of trachea here, almost becomes detached from the bifurcation at the level of the hilus, and you get this sort of floppy tracheal wall. So the tracheal wall remains intact, but you get this sort of floppy region where you've got this really weak tracheal wall as a result of that avulsion. Because the walls of the trachea there are very floppy, they can cause significant narrowing of the tracheal lumen. So if you imagine these floppy walls, they both flop inwards at the same time, then that's going to result in a very narrow tracheal lumen. As a result of that, these patients are really at a very high risk of severe dyspnea and death as a result of that. So I've not seen very many of these at all. I don't think we do see tracheal avulsions that often. We certainly don't see convincing radiographic evidence of tracheal avulsions that often, but that's what it looks like. Classically, it's a clearly marginated, round, gas-filled structure at the level of the highness, usually around T4, best visualized on radiographs, and in cats that have this structure, this tracheal avulsion, you'll not be able to see the dorsal and ventral walls of trachea because, like I say, where the trachea is sort of anchored, it's stuck at the hilus where it bifurcates. The body of the trachea gets pulled because of the manipulation of the neck during the accident, in this case an RTA, and it separates the trachea, so you get these floppy walls, and almost a bit like a diverticulum. So that's a nice example of a tracheal avulsion. So, having been through that example, what we're going to do now is to see if our online polling system is working. So I'm going to activate our first question, which is a very simple one, which is essentially, do you guys have any questions about this example? So hopefully, for those of you who have logged into Poll Everywhere, you will see this question appear and you can respond accordingly. So yeah, a couple of you have responded, which is good. So I'm just going to see if this will sync up. Let's see what the responses are. And if anybody has any questions about this example, then we can talk about it. Not simple. One sec. I'm just trying to sync that up again. Takes a few minutes. There we go. Now it's happy. Okay, fine. So everybody is happy with that example, which yeah, makes me happy. Okay, so let's move on to the next case, which is case number 1. So this is a 6-year-old female rooted greyhound presented to you as having a cough, and now it's become mildly asthenic. So I've given you guys 2 radiographs to have a look at. We've got a right lateral and a dorsiventral radiograph. So anybody feeling that they might like to just walk us through case number 1? So this is a pretty straightforward one, but one worth reviewing. Anybody fancy case number 1?
I can start it.
Yeah, good. This is there's no trick to this one. This is certainly something that you guys are going to see in first-opinion practice, and certainly something that's very important to be able to recognize on thoracic radiographs. So yeah, thanks Alan. Go ahead.
Great. So I'm not sure whether I got like the final diagnosis, but essentially what I've noticed in this radiograph is so moderate to severe pneumothorax.
Okay.
So the cardiac silhouette is raised from the from the sternum.
Yep.
And there's on the periphery areas where you don't see any pulmonary vessels. So that's how I concluded that from those 2 things.
Yes.
Is that what you call a silhouette sign? Maybe sort of cranial to the cardiac silhouette.
You're looking at this area.
Yeah.
Silhouette sign's not one I'm familiar with. I think what we're looking at here is just the edges of some long lobes. So okay. I think, yeah, just I'm not sure whether it's the right lateral, so probably the left cranial long lobe, maybe the left caudal long lobe, hyperinflated as a result of part of maybe the right lung lobe. We're just seeing the edges there.
The edge of it. Okay. Yeah. And then I was looking for fractured ribs or fractured anything skeletal.
Yeah.
But I didn't find any.
Yeah.
So I suppose it could be a spontaneous pneumothorax, or it could be still that I just haven't seen a ruptured organ like a trachea or esophagus.
Yeah. Okay. So your conclusion here is pneumothorax essentially.
Yes, yeah,
Yeah,
that's
okay.
good, yeah.
Yeah, no, I think I'd agree. So I absolutely agree with some of the radiographic features here that Anna's pointed out. So we have got elevation of the cardiac silhouette from the sternum. Very importantly, the area in between the sternum and the cardiac silhouette is almost completely radiolucent. In fact, it is completely radiolucent, so it's gas opacity. So we're not able to see any of the pulmonary architecture in that space, which suggests that it is gas. It's just gas within the pleural space. You get the impression as well that there might just be a little bit of gas within the dorsal there. We're able to see the margins of the aorta really clearly. So we've got really sharp dorsal and ventral margins with the aorta. And I wonder, maybe just superimposed over the ventral border of the aorta there, if there's not the edge of one of the lung lobes that's just retracted from the thoracic wall, again, as a result of the gas that's in the pleural space. So we can be pretty confident that this is a pneumothorax, and it's absolutely reasonable to then look for a possible reason why this patient might have a pneumothorax. And trauma would be a really good suggestion. So this dog doesn't have a history of trauma, so it's just been coughing and then become really dyspneic. But we don't often get, sometimes we don't get the whole story from the owner, so certainly worth looking for any signs of trauma. I absolutely agree that there really isn't any evidence of trauma. So all of the ribs look like they're intact. All the sternum are intact. There's not really any evidence of any soft tissue injury either, so not seeing any evidence of any soft tissue swelling or any emphysematous change that might suggest that this patient has suffered a penetrating injury. So this was a greyhound, and they do have a habit of running into sharp objects, giving themselves terrible injuries, and there's nothing here on the thoracic trunk in this radiograph to suggest that this patient has been injured in some way. In terms of mediastinal and esophageal ruptures and injuries, if this trachea had ruptured, if the esophagus had ruptured, then we'd maybe expect to see some evidence of a pneumomediastinum. I can't really see any evidence of the pneumomediastinum, so we're not really seeing any of the major vessels of the brachiocephalic trunk and the right claving here. And we can clearly see the dorsal and the ventral edges of the trachea. So I'm not convinced there's a pneumomediastinum here, which would make something like a ruptured trachea or ruptured esophagus less likely. So the only other things that I'd mention would be the serosal data of the abdomen is kind of poor here, but this is a greyhound, so it's most likely related to the patient's body condition rather than anything pathological. But it's probably something that I would comment on. So we can just about make out the edge of the liver here, and we can see some gas within the small bowel, but other than that, it's pretty fuzzy in there. So there is kind of poor abdominal serosal detail, probably because this is a greyhound. It's really thin, doesn't have a high body condition. In this DV, I really struggled to see the lung edges here. So in the lateral radiograph, it's really convincing that this cardiac silhouette is elevated, and I'm pretty convinced I can see some refractions of pulmonary parenchyma from the thoracic wall and the dorsal thorax. But looking at the DV, you're kind of thinking, well, am I really convinced there's refraction of the pulmonary parenchyma from the thoracic wall here? Certainly the edges of the lung look really radiolucent, but sometimes you can see that in very deep chested patients, or if you've just overdone the exposure slightly. I think this DV radiograph has been cooked a little bit, and because of that, it's really difficult to see any pulmonary architecture in the periphery of the lung in this thorax. And it's difficult to know whether that's because it's gas or because it's just overexposed. What I'd really like to see is a convincing lung edge that is being pushed away from the thoracic wall by the gas that's in the pleural space. And then there is maybe the suggestion that there's maybe a lung edge there, and that's being pushed away from the thoracic wall. It's harder to see on the left side here. We've got a little bit of interstitial pathogens coming in. There's a little bit of a bulge between sort of 1 and 2 o'clock in this cardiac silhouette, which is probably nothing represent on the artery. And yeah, that's it. So yeah, good job. Nice radiographic description, and I absolutely agree with your diagnosis, which is pneumothorax. So before we go on, let's just have a little bit of a chat about why the heart looks elevated in patients that have gas within their pleural space. So one of the most pertinent features, as I pointed out in this radiograph, is the elevation of the cardiac silhouette from the sternum, and it almost looks like the heart is sort of floating above the sternum. And that should really make you ask the question of why should the heart be floating just because there's gas in the pleural space? The heart shouldn't really float. And it isn't that the heart is floating, it's because the heart is falling away from the sternum as a result of the gas that's in the pleural space in the non-dependent part of the lung. So this is a diagram taken straight from Tracheal, so I take no credit at all for this diagram. So this is taken from Tracheal, 3rd edition. And I think it does a really good job of demonstrating why we see that gap between the cardiac silhouette and the sternum in these patients that have a pneumothorax. So essentially what happens is the gas fills up the pleural space in the non-dependent part of the thoracic cavity, and that squishes all of the lung on the non-dependent side, and it squishes the lung on the dependent side even more. And as a result of that lung getting squished up, the heart, which should normally be tucked up against the sternum here, because this lung is going to be fully inflated and pushing the heart in this direction and up against the sternum, just falls away from the sternum as a result of this lung getting squished up. And as it falls away, it's replaced with this gas, because there's gas in the pleural space, and it's that gas within the pleural space that's falling into this gap between the sternum and the heart that gives it that sort of floaty appearance. So yeah, that always puzzled me, particularly when I was studying for my certificate, as to why the heart looked like it was floating in these patients that have pneumothorax, and that's the reason. It's because the lung in the dependent part of the thorax collapses and the heart falls away from the sternum, and the gap that's left by the heart falling away from the sternum is filled up with that gas in the pleural space as a result of the pneumothorax, and that's why it kind of looks like it's floating. So great radiographic description from Anna, and totally agree with all of the findings. So the next question is what we do next. So hopefully you guys should see this question now appearing on poll everywhere. So do we think this patient would benefit from an echo? Now, we've got to a point with the radiograph description that we're pretty confident this dog doesn't have primary cardiac disease. So echocardiography is probably something that is less appropriate to go for. Should we do a thoracentesis? Certainly, if this patient has pneumothorax, and we're pretty confident that it does, then that would be a reasonable thing to do. Do we think this dog would benefit from a thoracic CT, or do we think we should do some more plain radiographs here? So let's see if you guys are responding, which you are, which is good. So let's just see if it's going to suck up this time. A little bit slower this time. Yeah, there we go. Excellent. Now it's woken up. Okay, so yeah, all of you guys reckon that thoracentesis would be the way to go, and yeah, I absolutely agree. I think that this patient definitely has a pneumothorax. It is dyspneic, so the amount of gas that's in that pleural space is clinically significant, as evidenced by the dyspnea in this patient. So draining that gas off is going to be a good idea. Now, we're confident about the diagnosis of pneumothorax. We're not particularly confident about what's caused it. And as a result of that, this patient went ahead and had a thoracic CT. So, I mean, really, if this patient hasn't suffered any trauma and there isn't a reason we can find for ear getting from the outside in, then what we're left with is, well, maybe it's ear that's come from the inside. So we should really be starting to think about the possibility of this patient having something like a ruptured bulla, so spontaneous rupture of the bulla. So we're just going to run through this thoracic CT scan and just see if there's anything that stands out, and anything that you guys are concerned about. So I'm just going to stop it there. Oh, no, I'm going to run it on. We'll stop it there. So for those of you who are not too familiar with looking at thoracic CT, so this is sort of cranial thorax here. So these are thoracic vertebrae, it's the scapula, this is the trachea, this is a cranial lung, this is a cranial lung. And hopefully you can see there's a difference between the right and the left sides here. So on the left side, we've got this hypo attenuating area, which essentially represents gas within the pleural space. So this is gas in the pleural space, and this dog did have thoracentesis performed immediately prior to this CT scan, and the vet who performed the thoracentesis removed tons of air, so I think up to a litre, maybe more of air from this dog's pleural space. But in the time it took for us to finish the thoracentesis and for this dog to go through the bore of the CT scanner, we've got more air that's turned up in this pleural space. So that's the pneumothorax that we're seeing. So I'm just going to carry on caudally, and you can see there's tons of air in the pleural space on the left there. That lung lobe is really squished up. So there's loads of gas on the left here, really squished up left caudal lung lobe. And then more and more gas. All right, so let's just go back and take another look at this and see if we can't see a reason for this patient's pneumothorax. So I mean, here we're just seeing gas in the pleural space on the left, and as we move caudally, we're still not really seeing anything convincing of the possible cause for this patient's pneumothorax. But if we go even more caudal, hopefully you guys will be able to see that there are very small little bully in the patient's lung. That's an example of one of them. And there are a couple just dotted around the lung here. So there's another one just under the cranial of that. So one there, which you already spotted. There's this structure here, which just linger on for a moment. So that I think is probably incidental chronic pulmonary infarct. So it's hyper attenuating. It's roughly triangular shaped, and it's right in the periphery. I don't think that's anything to worry about. That's probably just an incidental infarct. So there's another suggestion that there could be a little bully just there, really small. And in the left caudal lung, the shape of it is a bit strange. So it's really concave there. This left caudal lung. And just adjacent to it, there are quite a few, again, little sort of focal areas of hypoattenuation that might represent little gas bubbles, little bully limitation that way. So I mean, the working diagnosis for this dog was that it did indeed have a bulla that ruptured. And the thing to take away here is that when you're dealing with cases like this that have a spontaneously ruptured bulla, it's not uncommon to not see the ruptured bulla that has caused the pneumothorax, because if you think about it, you've got a kind of a big gas bubble within the lung, and that thing's popped, and that's the reason why you've got a whole bunch of gas accumulating in the pleural space. But immediately that thing pops, it's going to collapse, and the lung around it's going to collapse. So you're not going to be able to see it. So CT in these patients isn't particularly useful at finding out exactly what the cause was for the spontaneous pneumothorax. So I just pulled out a couple of papers that you guys might find interesting. So what I'm referring to is from way back in 2013, where Reeds looked at the sensitivity and QPV variability of CT diagnosing bullying associated with thorax. Essentially what they found was that CT isn't very good. So it's not uncommon to do CT in this patients not be able to see the bulla that is responsible for the spontaneous. Interestingly, there was another paper that was published in VetRad last year, so 2020, that sort of picked that up and builds on it a little, and just asked the question, well, if we were to do the CT different recumbency, does that increase the likelihood of us seeing bully specifically increase the likelihood that this bully was responsible for the spontaneous pneumothorax. And essentially what I found is, if you put the patient in sternal recumbency, you're likely to see bully within the dorsal line. If you put the recumbency, you're likely to see the ventral. So yeah, if you guys are interested in learning a little bit more about CT, about diagnosing pulmonary bully as the potential cause of spontaneous pneumothorax, then these two papers are good to look at.
If it shows me above
the other things to mention here would be,
then we may
go
have to
back to
repeat
that
the
dorsal
very
ventral
strong
radiograph, and
but we might
we
have
were
to
just musing as to whether or not this was a real pneumothorax, or whether this was just secondary to overexposure. The other thing that you could consider would be using a horizontal technique to try and demonstrate the gas that's in that dural space. So with horizontal beam technique, you have the patient in lateral recumbency, and you fire the beam horizontally from ventral to dorsal against a cassette that is essentially propped up by the patient's spine. And then what that does is, because all the gas is going to go to the lung-dependent thorax, it should really nicely illustrate the gas through space and the traction of that pulmonary wheel, and the complete lack of pulmonary architecture in the non-dependent. And that can be useful if you're really using as to whether or not this pneumothorax is smooth lines or not. If you're able to use the horizontal technique, then clear that up. So great, yeah, that was pneumothorax. That was a result of spontaneous rupture of solar. Are on that very subject. Okay. So good job there. That brings us to case number 2, which is an 8-year-old male muted greyhound again, so second greyhound disease. This one has a left-hind limb lameness. So what we've got a dorsal pointer, we've got the lateral, so anyone fancy having a go at this one, which orthopedic flavors?
So I'm going to send you through a copy.
Again, this one is not too tricky. There's no tricks to this one.
Run through those and see how we get.
So second greyhound. Anybody fancy just running through this? This is only orthopedic.
Sure, I can go ahead.
Yeah, no, that's great.
Yeah.
It doesn't look as if anybody else is too keen. Yeah, go ahead.
That's fine. So what I noticed were mainly focused on the I'm now counting either it's the I think the third digit.
That's what
Is that that's
yeah, so this is going to be something one we can't really see.
One,
So
okay,
2, 3,
3,
5,
4, yeah, fourth, I suppose. So there is soft tissue swelling distally around the second and third phalanges mostly. There is a fracture of the third phalanges, but I can't tell whether the joint between the second and third is involved.
Okay.
There is alongside the first and second cortices, sort of like a double line of mineral opacity, a bone opacity.
Yeah.
So I think that's my words are escaping me now. Sorry. Sort of a periosteal reaction is what I would say.
Yeah.
Yeah. So my conclusion would be that it's a pathological fracture. And so my next step would be to biopsy.
Okay.
So, yeah.
Yeah, no, that's fine. Which bit do you think this line here is a fracture?
I thought that was a joint, and then just distal to that was a fracture.
You're thinking here?
Yes.
Yeah. Okay.
But maybe not.
Okay. No, that's fine. So yeah, so we've got That's so distal phalanx, and then we've got middle, and we've got proximal, and then we've got metatarsal. And yeah, I absolutely agree that there is this raised periosteal reaction that goes right the way along the diaphysis of the middle, and also the proximal phalanx of digit 4 here. We've certainly got a whole bunch of soft tissue swelling, and it looks like there might be a little bit of gas in there potentially as well. So some emphysema, so something like a wound in this area, absolutely is a worry. We haven't spent too much time looking at the medial because, I mean, it's essentially not very useful, to be honest. It's really tricky to see any of those pertinent imaging features on this medial view relative to the DP. Okay. So do I have anything else to say about this? I mean, the only other things that I think I would mention would be that there's a whole bunch of sort of fuzzy opacities surrounding this pore. I think that's because this pore is probably bandaged when they've taken the radiograph, and it's just resulted in a lot of artifacts just adjacent to the bones here. So that's probably best avoided. So I'd always take the bandage off before taking radiographs. There's no left-right marker either, which is not great. So it's a left hind in lameness, and we're assuming that this is a left hind pore, but again, always good to have a left-right marker. All right, so now it's time for me to ask all of you guys what you are most concerned about. So do you think this is just a soft tissue injury? Do you think this is something neoplastic? Do you think this is an osteomyelitis? Or do you think there is something else going on? So you can cast your votes now. Okay. All right, let's sync this up. See how you guys are feeling about this particular case. All right. Okay, so a bit more of a mixed bag. So we've got 50% of you reckon this is an osteomyelitis. You've got some of you who think this could be something sinister, like a neoplasia. And we've got somebody saying, oh, actually, this could just be a soft tissue injury. Okay, so let's go back and take a look at this radiograph. So I don't really have anything else to add as regards the radiographic features here. So one of the things that I will say, and I'd say it cautiously because it is really difficult to differentiate between neoplastic lesions and infectious lesions of the digits. So the most common types of neoplasia that we are likely to see affecting the distal limbs, so the extremities, are things like melanoma and squamous cell carcinoma in dogs. And those types of tumors are going to have the same sort of aggressive features that we might expect from, say, an osteosarcoma affecting the shoulder or the femur. So we'd expect to see some cortical lysis. We'd expect to see an irregular periosteal reaction. We'd expect to see a long indistinct zone of transition. We might expect to see some soft tissue swelling. So we have got some of those features here. So we've certainly got this raised irregular periosteal reaction. It's affecting several bones. So we've got this raised periosteal reaction affecting the proximal phalanx and the distal phalanx of digit 4. So we've got two bones that are involved with a potentially aggressive radiographic feature, so this raised periosteal reaction. For the most part, this periosteal reaction is reasonably smooth. It's a little bit irregular, affecting this middle phalanx here, but it's reasonably smooth, particularly affecting this proximal phalanx. And if this was something like a neoplasm, particularly a primary bone tumor, then that would make it polyostotic because it's affecting two bones, and that would be unusual. If this was something like a squamous cell carcinoma or melanoma, it could be affecting multiple bones, but it would make it polyostotic, which again would be a little bit more unusual. The other thing that we're not really seeing convincingly is any sort of cortical destruction. So the medial and lateral cortices of this proximal phalanx and this middle phalanx here look like they're mostly intact. Actually, one of my colleagues was a little bit concerned that this patient might have a fracture, but I'm not completely convinced. We've not got, I think, enough evidence to make us believe that that's a fracture line here. This is the distal phalanx. This is probably the inguinal process of the distal phalanx here, and then that's the remainder of it. So that's the distal phalanx right out to the tip of the toe and the nail. So I wasn't entirely convinced about a fracture here. This is the joint space, so that's the distal interphalangeal joint. We do have the soft tissue swelling. So that's something that you might sometimes see with an aggressive lesion. But nothing else really. It's mostly just this raised periosteal reaction. And for me, because it is mostly just this raised periosteal reaction, and there isn't really much else going on apart from the soft tissue swelling. But when I interpreted these radiographs, I already knew that this patient had a soft tissue injury and a wound affecting this digit. So that's the reason why we've got this soft tissue swelling affecting this limb. I don't think that's secondary to the bony change. I think that's more the primary cause. So this patient has had a soft tissue injury that's become infected, and potentially now we've got infection of these bones. And because we're not seeing a huge amount of lysis, the most pertinent feature is this raised periosteal reaction. I think something like an osteomyelitis here is more likely. So this dog did have this cultured. I think the culture results, they grew a whole bunch of resistant E. coli and coliforms from the soft tissues here. So the working diagnosis with this patient was osteomyelitis. Now, the only other thing that I wanted to mention to you guys that you might want to consider having on your differential list if you see these sorts of changes. So a raised periosteal reaction affecting the extremities, so the digits, is something called Marley's disease or hypertrophic pulmonary osteopathy. So that's kind of a curious condition where you get a raised periosteal reaction affecting the digits mainly. So again, these are taken from Tracheal. This image here is taken from Wolf Dennis's book. Affecting the extremities, and it's often associated with thoracic disease, hence the pulmonary in the hypertrophic pulmonary osteopathy. So these patients, if you do see this sort of raised periosteal reaction affecting the digits, multiple bones are affected, then it certainly might be worth taking thoracic radiographs just to make sure that there isn't any evidence of any thoracic pathology. Now, curiously, this dog is a dog that we've encountered in film reading previously. So this is a patient that previously had a pulmonary abscess. So we're not going to go back and look at those images right now because I don't think we have time. But this dog had a pulmonary abscess and had a lung lobectomy to remove the pulmonary abscess. Now, I don't think the periosteal reaction that we're seeing in this digit is related to its previous pulmonary abscess. So I don't think the changes here are secondary to a hypertrophic pulmonary osteopathy, secondary to the previous pulmonary abscess that this patient had. But I think it's a good thing to be aware of. And certainly should be on the differential list here. And if you guys have never heard of hypertrophic pulmonary osteopathy, then that's what it is. So it's a raised irregular periosteal reaction affecting the medial and lateral cortices of the distal extremities, and it's often associated with thoracic pathology like thoracic dysplasia or infection like pulmonary abscess. So yeah, that's basically for anybody who not too familiar with hypertrophic pulmonary osteopathy. It should be on the differential list for this dog. And yeah, if you weren't aware of it as a thing, then now you are. So yeah, good job. All right. So that was.
Can I just ask a question about the gas? Does that make you sort of lean away from neoplasia as a differential at all?
Yeah, I think so. So I mean, if you're seeing evidence of episematous change, then it's much more likely to be a penetrating injury or a wound, and you wouldn't really expect to see that if this was a primary bone tumor that was causing swelling of the adjacent soft tissues. yeah, I mean, you really only see that if you've got a penetrating injury. It's really rare to have kind of gas-producing bacteria causing emphysema. So yeah, and the fact that we've got this leuciscine is just a suggestion there's an emphysema here. Again, we're peeling away from the places and say, well, this is likely to be a wound, and if this is a wound, it's much more likely that this is osteomyelitis rather than something sinister neoplastic like a squamous cell carcinoma or whatever. Everything else. But yeah, the main reason why I included this case is because I just was speculating as to whether or not these changes were as a result of this wound, as a result of an osteomyelitis associated with the soft tissue injury that this dog had, or is this just a leftover hypertrophic pulmonary osteopathy that we didn't see previously because there was no reason to radiograph this dog's left hairs when it was being treated for its pulmonary abscess. And then it sort of occurred to me that, well, actually, we don't really see too many cases of hypertrophic pulmonary osteopathy. It'd be a nice thing to have a little chat about and just make you guys aware of it as a condition if you guys weren't too familiar with it. Yeah, so that's the reason why this. All right.
Thanks so much.
Everybody else happy with this foot? Okay, then we shall move on to number 3, which is a very wee dog. So this is an 8-week-old male-neutered small crossbreed. This patient has presented to you with acute onset dyspnea. So we've got 2 radiographs, and we've got a lateral radiograph, and we've got a dorsoventral radiograph. So anybody fancy running through what we think might be going on here? So this is a really young dog, only 8 weeks old. That's a small crossbreed. It's a Tibetan Terrier cross, really acutely dyspneic.
Hey, and I'm happy to take it.
Yeah, go for it.
So I felt as though there was a diffuse severe alveolar pattern that I think was a bit worse cauda-dorsally. I think it would have been good to have the thoracic limbs pulled forward a bit more, but I think there's more bronchograms cauda-dorsally. I think there's border effacement of the cardiac silhouette. It's probably inappropriate to do this but I think I can just about make out the ventral border, and I wondered if there was increased sternal contact, but I assume I can't really make that call if it's all border effaced everywhere else. One thing that did catch my eye was just cranial to the carina. I think within the lumen of the trachea, I thought I could see a kind of well marginated ovoid soft tissue structure. Yeah, but I couldn't see it in the DV, so I wasn't entirely sure if that is something in the lumen or not. And even if it is kind of a tracheal foreign body, I guess I'd struggle explaining the kind of diffuse increase in opacity. I kind of thought that could be like non-cardiogenic edema from choking, but I think that's probably a bit of a stretch. I couldn't make out the pulmonary vessels. I think they're obscured by the kind of diffuse increase in opacity. So I've kind of left my differentials a bit broad. I've kind of said there could potentially be a tracheal foreign body, pneumonia, edema, hemorrhage, inflammatory disease. And if that is true about the sternal contact, then either kind of primary cardiac disease like pulmonic stenosis or something like core pulmonale secondary to respiratory disease. But I did find this a tough one.
Yeah, no, I mean, this is a tough one, and I very much agree with your description and with your radiographic findings. The thing that's most striking about these lungs is just the number of ear bronchograms. So we've got ear bronchograms everywhere. We've got ear bronchograms cranioventrally, we've got ear bronchograms around the iris, we've got ear bronchograms dorsocaudally. The only place where we maybe don't have any consolidation is just at the apex of the cardiac silhouette in this lateral view, but as a result of all of that consolidation, all of that infiltrate that is within the alveoli and within the interstitium, we can't really see any of that pulmonary architecture. We can't really see the borders of the cardiac silhouette. So there's effacement of all of those structures. And in this DV view, again, we've just got the world of their bronchograms. So we can sort of actually see almost all of the bronchi here. So we can see the trachea, we can see the cranial lobar bronchi, the caudal lobar bronchi. You can see the secondary and the peripheral bronchi. So I mean, all of this lung is just all consolidated. So it's just all filled with infiltrate. So whatever it is that's caused this, it is super severe because at the moment this poor little puppy has got very little lung that is being aerated, that is able to breathe through. So yeah, it's difficult to really pin down exactly what might be causing this. It's difficult to speculate too much about whether or not this might be kind of cardiogenic. So I'd probably describe the consolidation here as diffuse rather than aerial dorsal-caudal. So typically, cardiogenic edema is going to be around the hilus, it's going to be dorsal-caudal in dogs. Although if it's severe enough, it can be everywhere, I suppose. But we can't really see the cardiac silhouette in either of these views particularly well, and we can't really assess the pulmonary vasculature either. So difficult to be confident about this being kind of a cardiogenic edema secondary to an underlying cardiac problem. And thinking about something like pulmonary secondary to kind of pulmonary hypertension and chronic respiratory disease, this is a pretty young dog to be having those sorts of problems, much more likely to be something congenital and cardiac, which I suppose it could be. But again, it's so tricky to assess the cardiac silhouette and the pulmonary vessels in either of these views. That I mean, any sort of shout in terms of cardiac disease and primary cardiogenic edema is going to be a little bit speculative here. Could it be inflammatory? I suppose it could. It would be super severe. I'm not really sure of any sort of inflammatory condition that would cause this degree of consolidation. I mean, you can get really nasty viral pneumonias, but they have to be super severe to do this. What else could it be? Could it be hemorrhage? I mean, I suppose it could be hemorrhage. It doesn't really have the right distribution for something like lungworm, but I guess if this puppy had, if it was living on a farm and if it got into the rodenticide, maybe we could just be seeing a huge amount of hemorrhage into the pulmonary parenchyma, but tricky to know. So I think before we do any more speculating about what might cause this, I think I'm going to just activate the next question, which hopefully is what you guys are seeing now, which should give you an opportunity to just sort of point out what you think is the most significant feature here in terms of helping us work out what's caused all of this consolidation. And Giorgio has alluded to it, so it has already appeared in Giorgio's description of all the radiographic changes. And it's something that we just touched upon. It's something that I think is one of the most significant features of this radiograph. So let's see if you guys agree and you have spotted it. So I'm just going to sync this up and see if this one works. So these little pictorial questions I find a bit more unreliable in terms of syncing and working, but we'll see what happens. There we go, excellent. So let's take a look. So we've got 4 responses. 3 of you guys are pretty concerned about this clearly marginated ovoid soft tissue opacity that seems to be either within or superimposed upon the tracheal lumen, just cranial to the mainstem bronchi, the level of the hilus. We've got 1 response, which is not even on the radiograph, so let's hope that was a mistake. So yeah, I absolutely agree. That little structure there is something that I'm pretty concerned about. So it's difficult really to think that could be anything other than something intraluminal. So we can see gas around it, cranial to it. We can see gas caudal to it, completely surrounded. So my suspicion is that is a structure that is within the lumen of the trachea. And if that is a tracheal foreign body, then that might explain what we're seeing in the pulmonary parenchyma. So if this what we suspect to be a tracheal foreign body is and has prevented this puppy from breathing for any amount of time, then it's quite possible that all of that consolidation could be non-cardiogenic edema, secondary to this obstruction that's been caused by this tracheal foreign body. And that was certainly the working diagnosis in this case. So one of the things that I didn't tell you is that this unfortunate little puppy became acutely dyspneic after eating some kibble. So it was a new sort of dry kibble that this puppy hadn't been given before, and was presented as choking and markedly dyspneic. Yeah, we think it was probably as a result of aspiration of a little bit of this kibble, so there's soft tissue opacity within the trachea. And unfortunately, this puppy didn't make it, and went for a PM, and the PM confirmed that there was a huge amount of edema within the lungs. So this was edema. The pathologist wasn't able to find any evidence of any kibble either within the trachea or within the bronchi, but certainly our suspicion here is that was most likely the cause. So yeah, good spot. This little structure here, I think, could be a little tracheal foreign body, unfortunately responsible for that horrific non-cardiogenic pulmonary edema, which caused all that consolidation and ultimately resulted in this puppy's little demise. So I've not seen these sorts of tracheal foreign bodies very often. The only ones that I've seen, this one, I did see a little puppy once that managed to inhale a little cherry stone. And I guess it's all down to the size of these structures relative to the size of the tracheal lumen. So for whatever reason, this cherry stone and bits of dry kibble can cause problems. If you do some research into the literature, then there's not a huge amount of stuff out there on tracheal foreign bodies. You can get into kind of bronchial foreign bodies, and once you get into bronchial foreign bodies, then you start to get into grassholes and that sort of thing. And there was a paper back in 2010 that looked at, again, how effective radiographs were picking up tracheal and bronchial foreign bodies, and the answer is not brilliant. So about a third of thoracic radiographs you're not able to see the tracheal and bronchial foreign bodies, even if they're there. So about a third of the time you'll take thoracic radiographs and you'll have the same thing, and then the medic will go on with its scope and present you with a grassole that they've just taken out of this dog's lungs that you weren't able to see on the radiographs. So that happens about a third of the time. And if you do see it, then the foreign body, and we're talking about bronchial foreign bodies really now rather than tracheal foreign bodies, does tend to be caudal, and it does tend to be more right-sided rather than left-sided. So the thing to take away from cases like this, and I think the sorts of cases you guys are more likely to see in practice, are going to be all the dogs that have been running around fields and have inhaled grassholes rather than little puppies that are choking on cherry stones, is that radiographs are very good for ruling these foreign bodies in, but not so good at ruling them out. So if you're very suspicious that there's a bronchial or tracheal foreign body, even if you can't see them on the radiographs, then it's still worth taking a look with the scope, because about a third of them you're not going to be able to see on the radiographs. So yeah, that's another good bit for you guys to have a look at if you fancy doing some additional reading. So that brings us on to final case of the evening, which is case number 4, which is again a young dog. So this is a 2-year-old male neutered medium crossbreed, and this patient again is presented to you as dyspneic. So we've got a couple of radiographs here. We've got a left lateral, got DV. So just the 2. So anybody fancy having a go at case number 4? So don't forget, this is a young dog. So this dog's only 2 years old. He's dyspneic. Yeah, go for it. Great.
So we have 2 radiographic projections. One is a left lateral, and the other one is a DV of a skeletally immature dog. And there are generalized, poorly marginated soft tissue nodules, which they are randomly distributed through the lung parenchyma. These nodules have different dimensions, and some of them, they look like they are coalescing together,
Yep.
and they're causing partial effacement of the lung parenchyma, of the bronchial bundles and the vasculature of the lungs, as well as of the dorsal aspect of the cardiac silhouette.
Yeah.
And I mean, the dog is quite young, but for this reason, I would put probably as my first differential diagnosis fungal disease, although we know that in UK they are not so common. So I will probably ask any history of if the dog has been abroad or has been rescued from another country. Eosinophilic pulmonary granulomatosis, or lymphomatoid pulmonary granulomatosis. I will put also tuberculosis in my differential list, although all of these diseases, usually they are followed by lymphadenomegaly. And in this case, I cannot really spot any a large lymph node. Also in the DV, there is no diverging of the caudal bronchi. They look within the normal aspect, essentially. They don't look diverging. And potentially as a last differential neoplasia, because we cannot rule out, I will put round cell neoplasia, lymphoma, histiocytic sarcoma, and also carcinoma of unidentified primary neoplasia. Potentially the next step would be try to ultrasound and try to find needle one of the nodule, although in the DV they don't really look like completely like attached to the thoracic wall. Potentially on the right cranial, there is a good spot, potentially, but not really sure. I don't think in this case, to be honest, the CT would help to differentiate the nature of the nodules. Maybe a BAL.
Yeah, good chat.
Yep.
Okay. So excellent description. So absolutely, the main thing here is there are a whole bunch of soft tissue nodules, and as Nicoletta said, they're varying sizes. They're diffuse, so they're throughout the pulmonary parenchyma. They're occasionally coalescing. The sort of nodules that you might expect to see in a much older dog that had something like a pulmonary metastasis. But this dog is only 2 years old, and we've got no reason to suspect that there is a primary lesion elsewhere. So Nicola was absolutely right in terms of considering, well, what other potential causes might result in a nodular lung pattern in such a young dog. Because it's a young dog, something infectious, much more likely than something neoplastic. Absolutely, if this was a patient from the US, then a fungal pneumonia would be really high up on the differential list. Coccidioidosis, plasmodiasis, cystoplasmosis, that sort of thing. We don't really see it in the UK, but I didn't tell you whether or not this dog was from the US, from the UK. This dog is from the UK. As far as I'm aware, it's never been imported. So that makes something like fungal pneumonia less likely, and less likely that these are all little fungal granulomas. Something like eosinophilic pulmonary granulomatosis, I think, is a decent shout. So that's a primary inflammatory problem that you do see in younger dogs, and it does give you pulmonary nodules. So that's an inflammatory condition that might result in multiple pulmonary nodules that we're seeing here. And then other sorts of infectious disease, tuberculosis, you get nodules, yeah. I mean, they're pretty rare. I've definitely seen way more cats with TB than I have with dogs. And then what else could this be? So that's the next question. So I'm just going to activate the next one. Hopefully you guys can see it. Difficult really to pin down exactly what this is. So let's make it a little bit broader and let's say, well, do we think this is more likely to be something infectious? Do we think this is more likely to be something inflammatory? Or do we think this is a really unfortunate dog and it's actually got something neoplastic? And Nicoletta mentioned lymphoma, and certainly we see lymphomas in young patients. So is this a dog that has a lymphoma and it's just a bit of an unusual presentation? So let's sync this up. Let's see what you guys think. let's hope that pollen everywhere is going to behave itself. Okay. So vast majority have gone with something inflammatory, which is not unreasonable. And then we've got some people that went for infectious, which again, not unreasonable at all. So in terms of what this turned out to be, this dog has unfortunately gone for a PM. This dog didn't make it, and we're currently awaiting for the full results of the post-mortem. What I can tell you is that during collection of samples for histopathology, the vet did some impression smears, and on those impression smears, it was possible to see little larvae. So until we get the full PM results, the fact that we could see little larvae on the impression smears from the lungs, our working diagnosis here is that this dog actually had lung. And I'll update you guys when we get the full PM results. But certainly I can't think of anything else it would be, given the little larvae that we can see on those impression smears. Now, we didn't talk about lungworm, and I suppose lungworm would kind of come under the banner of infection, so parasitic disease, rather than sort of bacterial or fungal disease. But lungworm can absolutely cause hemorrhage, and with hemorrhage, you can get hematomas, and hematomas on thoracic radiographs are going to look like soft tissue nodules or masses. Now, this wouldn't be typical of lungworm at all. So, of the lungworm that I've seen, the pattern of change that you tend to get is more peripheral. So you'll see peripheral consolidation. So just around the edges of the lung on lateral radiographs, you'll see consolidation. So there'll be a peripheral infiltrate. You don't often see nodular change. In this dog, if it does indeed turn out to be lungworm, and that's our suspicion, that's how I presented. So multiple soft tissue nodules of varying sizes. I will keep you updated in terms of what this dog actually has when we get a full PM results. But working diagnosis for now is this lungworm for this dog. And like I say, very atypical. It tends to be kind of an interstitial peripheral infiltrate. We sometimes see bronchial thickening as well. And like heartworm, so another sort of parasitic disease, you'll not see any changes to the pulmonary vasculature, whereas in heartworm you tend to see big pulmonary arteries. This dog we think had lungworm, so a really weird case of lungworm. Presented as multiple soft tissue nodules of varying sizes. So there you go. I think one of the story is, keep lungworm on the differential list, because it can have all sorts of different radiographic appearances. Given it's a young dog, parasitic disease, definitely a differential list. All right, so that was case number 4. And that brings me to the end. Anybody have any questions about case number 4 or any of the other cases this evening? Because if you don't, then we'll just wrap a bow around this, and it just remains for me to thank you guys very much.
Sorry,
Yes.
Ian.
Yes.
Do you suspect Angiostrongelus vasorum?
Yes. So lungworm is our working diagnosis.
No way.
That's what the working diagnosis is. So I agree, very atypical, but that's our working diagnosis. I will keep you guys updated. Like I say, we should get a full PM report.
I will text
from
you.
This one. but certainly the initial cytology very suggestive of lungworm.
Okay.
So it is unusual, and that's kind of the reason why it's in, because
I pick always the weird one.
Well, I mean, you've got to have, out of the 4, you're always going to have one that's a bit weird. Okay.
Thank you so much.
Anybody else have any other questions about this one or any of the other cases? And as I say, we'll keep you guys updated in terms of the final histopath results on stuff.
With case number 3, is it typical for the non-cardiogenic edema to be that severe? Because I think that's what threw me off a bit.
Yeah, I mean, it can be really severe. It tends to have the same distribution as cardiogenic edema, non-cardiogenic edema in dogs. So it'll be alar and dorsal initially, and then as it gets more severe, more of the lung is going to get affected. But yeah, the severity certainly doesn't allow you to rule things out. So you can have non-cardiogenic edema, can be super severe, and that's what it was in this case. So for this dog, I can tell you with absolute certainty that this was edema, and it was non-cardiogenic edema, because we have had the full PM result back for this one.
Thank you.
All right. Any other questions? All right, great. Well, thanks to everybody who presented a case this evening. I think you all did a really good job. Special thanks to Anna for doing too. That's great. And yeah, have a lovely evening, and I will see all you guys next month for some more film reading. So yeah, thanks very much for joining me. Enjoy the rest of the evening. Enjoy the football on the weekend, and yeah, I'll see you again